Ladies and gentlemen, I am pleased to welcome you to the webinar Analytical and Clinical Aspects of Natriuretic Peptides, organized by the International Federation of Clinical Chemistry through the Working Group on Clinical Applications of Cardiac Biomarkers. My name is Jordi Ordóñez Llanos, and I will moderate the webinar. I am full professor of clinical biochemistry, University of Barcelona, and consultant of the aforementioned AACC group. If one asks himself why a webinar on natriuretic peptides could be of interest for any of us, the answer is, please, the first slide, that since the years 50, 60 of the past century, the existence of natriuretic molecules in the animals and humans was known, and later the main molecule was identified as the atrial natriuretic peptides. Since then, there is a long way to nowadays that has demonstrated that natriuretic peptides are capital and pivotal for the diagnosis, the prognosis, as even the management of patients of heart diseases, particularly heart failure. All these roles has been recognized on the most recent guidelines. The second slide, please. However, natriuretic peptides are heterogeneous molecules in the circulation, and their measurement and clinical use must consider several issues like the synthesis and secretion, the processing of the molecules, the different molecules circulating in plasma, as well as the recognition by part of the current assays that has been developed for measuring atrial natriuretic peptide, BNP, brain natriuretic peptides, and respective precursors or metabolic molecules. A part of these analytical issues that will be developed during the webinar, there are a number of other physiological and pathological issues as age, gender, that influence the upper reference limit, the obesity, different comorbidities, renal function, that is an important determinant of natriuretic peptide concentrations, pathological conditions other than heart failure that should be taken into account for interpreting natriuretic peptides on the clinical practice. So according to all these issues, we have structured a webinar addressing educational issues on the analytical, methodological, and clinical aspects of natriuretic peptides. For conducting all these educational session, we have three outstanding speakers. First is Professor Caroline Lamb, that we will talk on the clinical utilization of natriuretic peptides in heart failure. Professor Lamb is Senior Consultant Cardiologist at National Heart Centre, Singapore, and Professor of Duke National University of Singapore. She is recognized globally for her expertise in a special feature of heart failure, that is the heart failure with preserved ejection fraction. She is a world-renowned clinical trialist with her work as part of global steering committees of Paragon and Emperor preserved trials, contributing to the first improvement of therapies for heart failure with preserved ejection fraction that are available up to date. She was appointed in the 2021 Guidelines Task Force for the European Society of Cardiology Guidelines on Heart Failure, and has authored more than 300 articles in very reputed journals as New England Journal of Medicine, JAMA, Lancet, Circulation, or European Journal. She was recognized in 2021 as a highly cited research by Clarivate databases in the field of clinical medicine. She's also associate editor of Circulation Journal and European Journal of Heart Failure. Thereafter, we will talk on laboratory and assay analytical aspects of natriuretic peptides. This talk will be subdivided into two different talks. The first will be a charge of Dr. Amy Saenger, that is medical director of the clinical laboratories, director of clinical chemistry and point of care testing at Hennepin County Medical Center, Minneapolis, and associate professor of laboratory medicine and pathology at the University of Minnesota. Her clinical areas of expertise are mainly cardiovascular biomarkers and lipid lipoproteins, focusing on the utilization and analytical aspects of cardiac troponin and natriuretic peptides. She currently serves both at the ICC Committee of Clinical Applications of Cardiac Biomarkers and the Standardization of Cardiac Troponin I Working Group. Dr. Saenger has also authored more than 100 peer-reviewed manuscripts and book chapters, obviously primarily related to cardiac biomarkers. Finally, Dr. Pete Kavsak will complete the talk on laboratory and analytical aspects of natriuretic peptides. He is professor, Department of Pathology and Laboratory, and Molecular Medicine at McMaster University in Hamilton, Canada. He is also fellow of the Canadian Academy of Clinical Biochemistry, the American Association for Clinical Chemistry Academy, and the Canadian Cardiovascular Society. He is also biochemist and scientist within the Hamilton Regional Laboratory Medicine Program, primarily based at the Jorabinsky Hospital and Cancer Center within Hamilton Health Science, with a special dedication to clinical and academic aspects of cardiac and cancer-related laboratory tests. He has over 250 publications on the topics and others we have mentioned, and he is on the second term of the ICC Cardiovascular Committee. So, given the tremendous speakers we have, I think that without further delay, I invite Professor Caroline Lamb to begin her presentation. Thank you very much to all of you.
Thank you so much for the very generous introduction. I hope my slides are projecting well, and truly, it is my sincere privilege to be able to open this webinar with talking about a topic I'm so passionate about, heart failure, and especially working with the IFCC members, talking about natriuretic peptides, because I really have learned so much from being a part of the IFCC. So thank you to Dr. Ordonez that made this happen. You will soon see the following faculty after me, how brilliant they are. And also a real call out to Dr. Fred Apple. Hope you're watching. Thank you so much for making this possible. So first, as Dr. Ordonez already mentioned, I'm very, very privileged to be part of the ESC Heart Failure Guidelines Task Force, but to really show you how natriuretic peptides have entered into the very core of the diagnosis of heart failure. And these are the 2021 guidelines that show that while we start with the symptoms and signs of the syndrome of heart failure, the very next thing is to measure the natriuretic peptides. And there you see NT-proBNP and BNP mentioned, following which echocardiography and the classification of heart failure into the different kinds of heart failure is recommended. Now, this is followed hot on the heels, just very hot off the press. The 2022 ACC AHA Heart Failure Society of America guidelines that also similarly advocate starting with an assessment of the clinical signs and symptoms, followed immediately by natriuretic peptides and echo for the diagnosis of heart failure. So it's a very key component for the diagnosis of heart failure and management thereafter. Here you can see that guidelines are now very consistent in the classification of heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction, and that is based on the left ventricular ejection fraction. And the ACC guidelines go further to say that serial assessment is needed. And in fact, a very new component of the new guidelines is to consider the entire trajectory of the patient's journey, which requires not only evaluation of biomarkers at the beginning in patients with dyspnea, as you can see, the top left, which is a class 1, highest class of recommendation. Also, in patients hospitalized for heart failure, it's strongly recommended to check the natriuretic peptides to establish the prognosis even. And a sort of a lower class 2A recommendation to do a pre-discharge natriuretic peptide. Even in the chronic situation, it's class 1 recommendation to measure the natriuretic peptides for risk stratification. And then finally, even before one has heart failure, in a pre-heart failure setting, there is a class 2A recommendation for natriuretic peptide testing. Now, let us go through this in greater detail, also considering this special educational recommendations that the IFCC reported. I will cover the clinical recommendations of this report. And one of them is, we recommend that age-stratified cutoffs for BNP to rule in acute heart failure should be validated. And it should be similar to the approach done with NT-proBNP. Now, let's look at some of this data on age-stratified cutoffs for NT-proBNP. So here is the PRIDE trial, and it was performed in 600 patients in the emergency department with dyspnea, in whom the final diagnosis was made in 35% of them. And this was one of the earliest study that established an NT-proBNP rule-out optimal cutoff in an acute, note this is an acute emergency department setting, of 300, which really provided a sensitivity, there you see it, of 99% and a negative predictive value of 99%. And here it was found that the rule-in cutoffs varied by age, with 450 in those less than 50 years old and 900 in those 50 years and older, being the one with the optimal sensitivity and specificity for the diagnosis. Here it is summarized again and found in the ICON trial. This time, 4 prospective studies combine a much larger series, twice as big, more than 1,200 patients, of whom more than 50% had that final diagnosis of acute heart failure. And again, exclusionary rule-out cutoff optimally at 300, rule-in varying by ages of 450 for under 50 years old, 900 for those between 50 and 75, and even up to 1,800 in those above 75 years old. Now, because that was done in 2006, and there's been a lot of changes in treatment, ICON Reloaded was done 12 years later, published in 2018. Again, a large cohort of patients presenting still in the emergency department. And here you will see that a smaller percentage had the final diagnosis of 19%. And these were very similar to contemporary patients, so multimorbidity, with the final finding being that, again, that cutoff of 300 had excellent negative predictive value, and the age-adjusted cutoffs were really proven to have good sensitivity, specificity, and accuracy overall for the diagnosis of acute heart failure. Now, because the prevalence of acute heart failure was lower in this study compared to previous, of course, the positive predictive value was lower, but it was still very reinforcing and consistent with prior results for NT-proBNP. And very importantly, because this contemporary cohort had a mix of patients with low versus normal GFR, low versus high body mass index, presence and absence of atrial fibrillation, so a very real type of cohort we see, it was very important to see that the diagnostic and exclusionary performance of the test remained accurate in the presence of these comorbidities. The second thing that we recommend is that additional studies evaluating natriuretic peptides in diverse ethnicities are needed. Now, why do we say that? Well, there is good evidence that US Black versus white adults in the REGARD study had lower NT-proBNP in the absence of cardiovascular or renal disease. In fact, 27% lower. And in this study, when a meta-analysis was done in similarly healthy, so-called population-based adults from the Dallas Heart Study, or ERIC, and there you see that graph on the top, there was in totality a 35% lower natriuretic peptide level among Black than white people. Importantly, however, this study showed that regardless of race, the prognostic utility of NT-proBNP, meaning its association with all-cause mortality, cardiovascular mortality, or even non-cardiovascular mortality, was similar in Black versus white patients. How about Asian patients? Well, we looked at that in our SHOP versus people studies, and SHOP was done in Singapore, people in New Zealand. And if you look at the baseline population that was studied, you immediately notice that patients in Singapore were much younger, of course, multi-ethnic Asian compared to predominantly European descent in New Zealand, Asian in Singapore, that's where I am here talking to you all. And the patients with HFpEF in Singapore had a lower NT-proBNP level on average, but similar natriuretic peptide levels in those with mildly reduced ejection fraction and higher than in whites in those with heart failure with reduced ejection fraction. The important take-home, though, very similar to the REGARDS study, was that the prognostic utility was the same regardless of race. Regardless of the differences in baseline characteristics and baseline level, prognostic utility was the same. Here, showing the main outcome that patients with HFpEF who had lower natriuretic peptides tended to have a better outcome than those with HFrEF. But if we looked at the independent predictors of all-cause death, older age, ischemic etiology, New York Heart Association, worse status, a lower blood pressure or higher creatinine, but very importantly and most prognostically important, a higher NT-proBNP. And this didn't matter which ethnic group you looked at. The next recommendation we have is a negative recommendation, which is a natriuretic peptide biomarker guided strategy of treatment in heart failure cannot be recommended at this time. So far, we've been talking about diagnosis and prognosis, but not in guiding treatment. And how do we arrive at that? Well, that is from the guided trial, which really randomized patients who had a high natriuretic peptide and had a recent heart failure hospitalization into a biomarker guided treatment strategy where doctors had to aim to suppress NT-proBNP to less than 1,000 to usual care. And you can see in the outcomes, whether the primary outcome of first heart failure, hospitalization, or cardiovascular death was exactly the same in usual care versus biomarker-guided therapy. In fact, the trial was stopped early for futility. Now, if we look into why, I mean, this is a biomarker that associates so much with heart failure, it's prognostic. What happened? Well, in essence, if you look at the two arms of the trial, and if you scroll down these therapies that were used in the trial, you can see that there was no difference in the guideline-directed medical therapy uptake or even up titration among the two groups. So, in other words, in the guided group, doctors knew the NT-proBNP, but they were doing the exact same thing as doctors in usual care. And there was no difference in biomarker changes over time. And I think you can predictably then say that there was no difference in clinical outcomes. So perhaps this is a failure, not so much of the biomarker, but of the execution and translating it into more intensive guideline-directed medical therapies for patients who need it. The next recommendation, comorbidities that influence natriuretic peptides, of course, must be addressed and considered when interpreting results. And what are these? Well, increasing age, the presence of concurrent acute coronary syndrome or renal insufficiency, right versus left-sided dysfunction, atrial fibrillation, all these conditions that tend to increase natriuretic peptides to higher levels than may be explained by the heart failure alone. On the other hand, in the presence of obesity, in the presence of pulmonary edema that develops very quickly, what we call flash pulmonary edema, when it's pericarditis that's producing the symptoms and signs, in these situations, natriuretic peptides may be lower than one would expect. Now, one question that comes up is, okay, we talked about the 300 exclusionary limit in acute heart failure, and we talked about all the inclusionary age stratified limits. What do we do about the gray zones? So this is beautifully answered in this study of more than 1,200, again, acutely dyspneic patients in an international multi-center trial. The gray zone was defined, as you can see here, between the rule out and the rule in values. Now, they noticed that if you use age stratified values, that reduces the gray zone results, however, not eliminates it. And almost 20% of patients will still have values in the gray zone. The first important lesson is rule out differential diagnosis in these patients, like the lungs, like the right side of the heart, and all the other things that we had also mentioned before that can raise natriuretic peptides. And the next thing to understand is that for patients in that gray zone, look at the two curves in the middle of these Kaplan-Meier. They are people with the gray zone NT-proBNP. One of them has a final diagnosis of acute heart failure and the other doesn't. And notice the survival is actually the same. So it is very important not to just discard these people in the gray zone. Don't just say it's false positive, nothing's the matter, because they still have a worse prognosis. So that's the very important lesson from this paper. And nearing the end now, this recommendation is of course very, very pertinent to current times when ARNI or sacubitril/valsartan, which is angiotensin receptor blocker with a NEP inhibitor, are really first-line therapy now for heart failure. So can we still use natriuretic peptide tests in the patients who are receiving ARNI? Well, why is there confusion in the first place? Well, the neprilysin inhibitor is known to inhibit the degradation of BNP, for example, but also ANP and others, but it does not impact that of NT or pro-BNP. So it should not impact levels of NT-proBNP, but it may impact levels of natriuretic peptides by a mechanism of action rather than in a way that signifies worsening of heart failure, which is how we usually use it. Do we have data to show that? Well, indeed, in Paradigm Heart Failure, which is the phase 3 trial of ARNI in heart failure with reduced ejection fraction, you can see in red the NT-proBNP levels across time, and in blue the BNP levels. And look first at the blue, and indeed, in the sacubitril/valsartan arm, there appears to be an increase over time, though somewhat maybe falling off after some time. Whereas if you look at the red curves, there is a reduction in NT-proBNP that remains sustainably reduced with sacubitril/valsartan, bounces back up with enalapril. So, in short, can BNP still be used for diagnosis of heart failure? Well, the BNP concentrations rose after randomization in Paradigm, like I showed you. In fact, it doubled in almost 1 in 5 patients and tripled in some. And these doubling and tripling, we think, is the effect of the medication. Whereas, because neprilysin inhibition doesn't affect NT-proBNP, such increases were very rare for NT-proBNP. So, to reduce confusion, the recommendation is use NT-proBNP, especially within 8 to 10 weeks of starting ARNI. However, I want to very, very carefully distinguish the diagnostic utility of natriuretic peptides with its prognostic utility, because here you see, whether we talk about BNP or NT-proBNP, these were clearly associated with prognosis in patients in the Paradigm study. And in fact, we saw that in the Pioneer heart failure study, where now these were hospitalized heart failure patients with reduced ejection fraction, and NT-proBNP change was indeed the primary outcome, was significantly lowered by sacubitril/valsartan, and this translated with a reduced composite cardiovascular death or heart failure rehospitalization. If we were to now look at Paragon heart failure in heart failure with preserved ejection fraction, we see the same thing. Natriuretic peptides at baseline really correlates with prognosis, and a higher baseline NT-proBNP identifies patients with high risk. Importantly, NT-proBNP does not modify the benefit of sacubitril/valsartan in HFpEF. So you can see the hazards are all below 1 for treatment effect across any level of NT-proBNP. And now finally, to end with the message on patients at risk for heart failure. This is an area that I am personally so interested in. It's a 2A recommendation based on the Pontiac studies that really randomized patients with diabetes with a high NT-proBNP into an intensive preventive treatment arm versus usual care, and showed that intensively treating these patients who didn't have heart failure yet, only had a raised NT-proBNP, was effective in reducing future heart failure. And in fact, right now, we are also performing an Asian version of Pontiac, if I may, a multinational study, similarly randomizing patients with diabetes, but no heart failure, no cardiovascular disease yet. And if they have a high NT-proBNP of above 100 or 125, we will randomize them to intensive preventive therapy versus usual care, and that is ongoing. And with that, I will stop here. I know my 20 minutes are up, and just thank you very much again for allowing me to share.
Okay. Caroline, thank you very much for your interesting talk. So we should have some time for questions. And I am just reviewing some questions. One is coming from Dr. Fred Appel. Sorry.
Fred, no fair.
Yeah, no fair.
No
I have
trick questions.
is the neprilysin effect on VNP assay dependent as the paradigm study only used one assay type?
You see, that's the thing. I bet Dr. Apple knows more the answers than I do. I'm afraid I don't know if other essays were used. And in fact, I have to tell you that I've humbly learned that the different assays actually locate different epitopes and different parts of the NT-proBNP or the entire proBNP chain, which I didn't really realize before as just a simple clinician. And so it's a very smart question, but I don't have the answer to that.
Yeah. In very similar issue from Dr. Yan Liu, what could influence the decision to use BNP over NT-proBNP or vice versa?
That is a very good question. I have to admit that in many of our heart failure practices and heart failure trials, more and more we are shifting to NT-proBNP. Now, that's not to say that BNP results are not similarly clinically meaningful, but the issue I also think is the fact that NT-proBNP has this stability that we've been told as clinicians. The other thing, of course, is the point of care testing that has become available. And finally, the use and increasing use of neprilysin inhibition as foundational therapy in heart failure with reduced ejection fraction really, really makes it very convenient for everyone to sort of say, why don't we just measure NT-proBNP all the time? So I think the cases where BNP is still used is really quite a legacy effect. So it's with labs that have been using BNP from the start and, don't see an impetus to change. But I can tell you, I do not see a need to measure both, for example, in a patient. As long as I have one, I am happy.
Okay. This is a question that, in that case, coming from the moderator, because you mentioned the need to obtain upper reference limits based on age and sex, but most of clinical work has been developed comparing results against those derived in acute heart failure, in differentiating acute or chronic heart failure patients from the normal people. So now the companies are releasing upper reference limits in their insource, but they are not coincident with the same values they are recommending for differentiating between health and diseased people. How is your point about this?
Oh, wow. I would really appreciate your thoughts here too. So let me first clarify that our recommendation when we wrote it was that there are data supporting age stratified cutoffs for NT-proBNP, but not as robustly evidenced for BNP. And so that's what we were saying, that we need a proper investigation of age stratified cutoffs in heart failure for BNP as well. So that's I just wanted to clarify that was the recommendation. It's true that it is confusing, frankly, what should be the optimal cutoff. It's true that guidelines for chronic heart failure, and in fact, the guidelines are now consistent, use 125 for the
Mm,
rule out for
yeah.
NT-proBNP and 35 for the rule out of BNP, and don't even talk about age. And I think that, and frankly, don't include age stratified rule in criteria. So when we write guidelines, I think we need to give clinicians, because we're actually quite simple-minded, sort of one safe thing and to use and to remember. And so it's an exclusionary cutoff. And I think to the audience, that's the most important thing to remember. This is an exclusionary cutoff, not an inclusionary cutoff for the diagnosis of heart failure. And it's for the chronic heart failure setting.
Okay, thank you, Dr. Lam. And I would like to remember to the audience that all questions that cannot be answered online now during the meeting will be answered online after the meeting. So don't worry by not having the questions and the answers, because now there are 4 questions that have reached the box. But unfortunately, we should in order to maintain our time schedule, we should to move to the next speaker. And don't worry, your questions will be answered online. So next speaker will be Dr. Amy Sanger, that will initiate the topic of natriuretic peptides, laboratory and assay analytics. I imagine that most of us are clinical laboratorians, so we will be very interested on how to manage in the clinical lab the measurement of natriuretic peptides and the factors we should take into account to obtain the best behavior of our test to serve the clinicians. So please, Dr. Sanger, when you wish, you can open your presentation. Thank you very much.
Okay, I'm having an issue. So I'm having issues trying to share this now.
Wow.
I
understand you.
I know you do. Okay. I cannot, it's not allowing me to share my, I don't know if the support group,
but we have your slides.
You have my slides, right? Oh, there you go.
No, perfect.
Okay. That works too. Okay. So sorry for the technical issues, everyone. And I would like to thank Dr. Ordonez and Dr. Apple for the opportunity to speak on this topic. And I will cover part 1 of some of the lab and assay analytic issues with natriuretic peptides. Dr. Kavsak will follow me and talk about the second half. Next slide. And so really our IFCC Committee on Clinical Applications of Cardiac Biomarkers has evolved. It was originally a working group and then evolved into a full committee under the leadership of Dr. Apple and previously Dr. Ordonez. So our mission really is to develop different educational materials about cardiac biomarkers, specifically related to troponin and natriuretic peptides. And then our goal is also to develop educational opinion materials in collaboration with other IFCC committees or AACC to really give guidance and to how to thoughtfully use these biomarkers in practice. Next slide. And you might just have to click a few times, Jordy. So really, we've kind of evolved over the years. We've had a lot of fun together. We've had a lot of collaborations together. You can keep clicking, and we've gone to some fun places, and now we're kind of just in this virtual state. So we're hoping to see each other live and in person again soon, because the things that we're doing and trying to move ahead, it's really sometimes it's harder to do virtually, as I think everybody can appreciate. Next slide. And so one of the educational materials and papers that we published has to do with analytical interferences from things like hemolysis and biotin. And we actually publish an update on a fairly regular basis some of these materials on our IFCC CCB website. Next slide. And so it might be a little bit difficult to see and appreciate. There's a lot of material that's actually on the website. And so we have, one table that's dedicated to cardiac troponin and one table that's dedicated to the natriuretic peptides that outlines, and this is all information that we've gleaned from the manufacturers on hemolysis, the thresholds that they use to assess whether there's significant interference or not. And we also have that information related to biotin. Next slide. And even though we know that, and this could be true for a lot of the assays that we measure in the laboratory, we know that hemolysis can either positively or negatively affect, troponin results. This is an example from a recent study. And we know that biotin can also cause false positive or false negative, depending on the assay. This study just really highlighted the importance of looking at the two different analytical interferences together, because obviously, for both natriuretic peptides and cardiac troponin, when you're looking at changes, either acutely over time or chronically over time, and you have different interferences, that can affect the clinical interpretation of the results. Next slide. And so there have been two recent special reports that our IFCC group has put together, one for cardiac troponins and, as Dr. Lamb nicely mentioned, one for the natriuretic peptides, and that's what we'll be going through. Next slide. And the recommendations for natriuretic peptides, the ones that are in red, are actually pretty similar to high sensitivity cardiac troponin, and has to deal with the interchangeability of assays, the validation or characterization of assays prior to implementation. I'll be talking a little bit about the reporting of upper reference limits stratified by age and sex from more of an analytical perspective, as Dr. Lamb covered that nicely from the clinical perspective. The issues related to standardization and harmonization of assays, and then some recommendations on improving the assay analytical imprecision. There are differences between natriuretic peptides and high sensitivity cardiac troponin recommendations that really focus on more for troponin, the lower limits of reporting, the criteria that defines a high sensitivity assay, things related to turnaround time, and then biological variability. Next slide. And those documents actually replace previous, which was the former NACB, now AACC Academy, documents on the quality aspects of natriuretic peptide assays. So those reports are kind of retired, and we have our two new recommendation documents. Next slide. And one of the recommendations has to do with quality control, and I've compared, contrasted cardiac troponin with the natriuretic peptide recommendations. So for high sensitivity troponin, we know that labs should measure 3 different concentrations of QC materials, and I've highlighted them in the 3 bullets. And for natriuretic peptides, essentially the recommendation is that the analytical precision of the assays should be improved to allow for refinement of significant clinical changes. Because again, as Dr. Lamb highlighted, we're looking at, whether it's acute changes or chronic changes. The more analytically, precise the assays are, the more that the clinicians can be guided in terms of either assessing heart failure or monitoring chronic heart failure. Next slide. And this was a recent study that a couple years ago published by Dr. Kavsak, and really looked at assessed the impact of acceptable analytical variation on potential risk misclassification. And that would really go from like low to moderate risk. And so looking at the importance of maintaining that acceptable analytical precision over time. And when that kind of changes, people can be misclassified in terms of cardiovascular risk. For natriuretic peptides, essentially a 30% change in natriuretic peptide concentrations over time within an individual patient has been claimed to be a significant change within heart failure trials. So we recommend a target CV of less than 10% to improve the analytical performance of natriuretic peptide assays. And the previous documents over a decade ago, the recommendations were less than or equal to 15%. Next slide. And so in terms of finding some solutions, a lot of the things, so this just shows different plasma pool QC and at different levels. A lot of our quality control materials that we have within the laboratory for both cardiac troponin, high sensitivity troponin, and natriuretic peptides, often they aren't at relevant concentrations that we, would look at either, at the 99th or below the 99th percentile, or within the relevant clinical cutoff, as shown here. So you can use plasma pool QC to kind of monitor analytical imprecision over time at relevant clinical cutoffs. And the figure on the right is just a Kaplan-Meier curve, which looks at 30-day risk for myocardial injury after non-cardiac surgery. And you can see that this is for NT-proBNP, but the different thresholds vary, but we want to make sure that we're actually monitoring analytical variability over time so that we're looking at these, relevant concentrations. Next slide. And the Canadian Cardiovascular Society guidelines actually recommend measuring NT-proBNP or BNP before non-cardiac surgery, again, to just enhance perioperative risk estimation. And essentially, again, they have cutoffs of NT-proBNP less than 300, BNP, less than 92. And so again, making sure that we have appropriate analytical and precision at those relevant levels when they're looking at risk assessment will be extremely important. Next slide. In terms of upper reference limits, as you know, for high sensitivity troponin, we recommend that use a defined reference population to report 99th percentiles according to sex-specific cutoffs. And this is, again, for high sensitivity troponin, not contemporary assays. And as Dr. Lamb mentioned, we also recommend that upper reference limits for natriuretic peptides should be stratified by age and sex for a lot of the reasons that she highlighted. And there are clinically significant differences. A lot of times, if we see that there are male and female, appropriate reference ranges, that's generally what we report and adopt. But that may be different than the actual clinical relevant clinical cutoff that they're using in practice to either diagnose or monitor heart failure. Next slide. And this slide just shows, for troponin, it just shows that it's the ratio between what our guideline recommended healthy population at 99th percentile is in terms of factoring out, with different biomarkers versus what the manufacturer's published reference interval, 99th percentile is. So the lower that the ratio is, the more discrepant the 99th percentiles are. And so it really just depends on how you define your healthy reference population. Now for natriuretic peptides, we do on our website, this is another area that we keep updated fairly on a regular basis for both high sensitive troponin and natriuretic peptides. We have all of the company's assays, and this is taken from the manufacturers. We have their limit of detection, their percent CVs, what the recommended upper reference limits are, and kind of the patient population that they use to determine those upper reference limits. So it's a resource that I think a lot of people have found beneficial, and one of our probably more visited educational documents on our website. Next slide. And in terms of comparability of testing for both troponin and natriuretic peptides, and I think, saying this to laboratorians, I think you can appreciate it's probably pretty intuitive, but using different natriuretic peptides in clinical practice or for troponin is not recommended, just due to the complex nature of natriuretic peptide processing and cleaving, and there's many differences in what the assays measure in terms of the different natriuretic peptide fragments or the effect of glycosylation. So we do recommend that there is further development of higher order reference methods, commutable standards for BNP and NT-proBNP, with standardization efforts to consider those differences between the different fragments detected between different assays and the effects of glycosylation. Next slide. And this slide just highlights in terms of differences between, whether it's cardiac troponin or natriuretic peptide. I think we all can appreciate too that you can't just use a BNP. Even a BNP to another BNP assay is not the same, and NT-proBNP assays are also not necessarily going to give you the same results. But particularly when you look at between BNP and NT-proBNP, it's really hard to kind of find a trend in when we just even visually look at those results. So essentially stick with one assay and don't interchange them, and the recommendation also would be to don't have both available within a single institution, ideally. Next slide. And then for reporting units, they are also similar. So cardiac troponin, natriuretic peptides, both. We encourage the use of mass units or SI units in nanograms per liter, as opposed to picograms per mil or picomoles per liter. And for natriuretic peptides in particular, it's a lot of that comes from the known post-translational modifications that occur heterogeneously in natriuretic peptides. And so reporting that in terms of a concentration like picomoles per liter is not recommended. Slide. And so in summary, essentially we looked at interchangeability of assays. So using different ones in practice are not recommended. Validation and characterization of assays prior to implementation. So essentially know your analytical characteristics and potential interferences associated with your specific natriuretic peptide assay. Reporting of upper reference limits, again, report in nanograms per liter, stratified by age and sex. We recommend developing higher order reference materials and commutable standards for natriuretic peptides. And then again, for improving the assay analytical imprecision, a target CV of less than 10% is recommended, as opposed to the previous recommendation of less than or equal to 15%. And with that, I guess I don't have to stop sharing my screen because Jordy's sharing my screen. So,
okay.
Thank you.
Thank you so much, Dr. Saenger, for the interesting presentation that has produced some questions in our audience. One of the questions is referred to the use of 3 quality control levels. And the question is, it is necessary to use a 3-level QC control, or it is possible to use only 2-level control, normal and high? What is your answer to the question?
I mean, I think it probably depends on your regulatory body, but I mean, I think, you know, you have to have at least 2 levels of controls. But again, like when we look at a lot of times our manufacturer QC, they are not necessarily even within our normal reference range. And then you have like something that's extremely high. And so you're not really hitting the regular cutoff. So I would recommend using 3 levels of controls. Again, also for things like high sensitivity troponin, you can run like a serum pool over time to monitor those very low concentrations in addition to your 3 levels of quality control. That's kind of going above and beyond, but that would be my answer.
Thank you. Other interesting question is, what would be the ideal reference material look like to harmonize the natriuretic peptide assays if possible? What is the measurement?
Oh, that's a good question.
Yeah.
That's a tough question.
It's hard question. Thank you, Dr. Roventhal.
Yeah, yes. I don't know if I have immediate answer to that question. I think that's been kind of the struggle in the end to look at even just harmonizing assays, because developing a higher order reference method, and what are you gonna trace that back to?
Yeah.
It's
Miami, I think that is similar to the fact it happens with troponin I.
Yeah. Yes, I agree. I don't have a good answer to that question, but I think that's one of the struggles of that has kind of hindered some of the standardization efforts for both troponin and natriuretic peptides is trying to figure out what is that going to be that final measure and.
And I think that the final question is regarding the use of units for expressing natriuretic peptides. And the question is, especially in the light of variations in glycosylation and thus in the molecular weight of natriuretic peptides, would it not be preferable to use picomole, milliliter, or other, as this gives comparable concentration for all variations?
So I think, so the question is to why not picomoles per liter?
Basically, instead of using nanogram or picogram, to use picomole or nanomole, or using the molar unit.
Yeah, I mean, I think that just the recommendation to not use picomoles per liter has to do with just like I mentioned before, the known post-translational modifications that occur just heterogeneously with natriuretic peptides, and that can be like degradation, glycosylation, and things like that. So that's kind of just why we had recommended nanograms per liter.
I think that until we don't have true standard for the standardization of tests. Knowing what is the standard, we cannot recommend the use of molar units. Do you agree?
Yeah. Yes. Yep.
Well, finally, on one last question, just the end. Why, if you recommend to make serial measurements and look at variations of no more than 30% or more than 30%, there is some preferred time schedule to conduct this? Days, hours? I don't know. I think that there isn't any recommendation regarding a time schedule to measure.
No, we
I
don't.
don't know whether any guidelines recommend something in this regard.
Right. No, I agree. I don't think there's one.
Yeah. So I think that this cover all the questions. So the questions that remain to be unanswered will be online answered. So don't worry for having an answer. So finally, Dr. Pete Kavsak, that is one of our principal authors and drivers in the group of IFCC regarding natriuretic peptides, will finish the issue of laboratory and assay methods. So, Dr. Kavsak, is your turn. So the session is open for you.
Okay, thank you so much. Let me see, can everyone see my screen? Okay, so thank you very much for the invitation to talk about the second analytical part regarding natriuretic peptide testing. I think one of the things that was highlighted before by Dr. Saenger, which is really important, is the fact is that part of the emphasis of the Committee on Cardiac Biomarkers of the IFCC is to educate laboratory professionals as well as clinicians on the clinical utility and analytical utility of various cardiac biomarkers. And one way in which we do that is that we actually sometimes comment on more recent guidelines or definitions. And so in this manner, what I'm going to actually talk to you today about is actually the IFC's take on the most recent universal definition and classification of heart failure, which was put out last year. So I do have some speaking disclosures that are listed here, but for purposes of this talk, I will be not talking about any intellectual property outside of the current presentation. Okay, so the learning objective today is kind of twofold. One is to first talk about this rebranding of the natriuretic peptide. And I think you could actually sense it right from the beginning with Dr. Ordena's talk and regarding about the utility of the natriuretic peptides, followed through with Dr. Lamb, because it's just not a biomarker that's for congestion. The second thing as I want to touch on is actually our committee's recommendations regarding our thoughts on the current proposal for the universal heart definition. Okay, so what do we mean by rebranding natriuretic peptides? So as probably most know, last year in January was a special issue in Clinical Chemistry on cardiac biomarkers, and it's freely available. And I would really encourage if people haven't taken the opportunity to read that issue. It's a fantastic issue, great editorials, a great review and many reviews, and of course, really insightful publications. But one editorial that was really, I thought, thought-provoking was one by Dr. Januzzi, where the title says this rebranding of natriuretic peptides. And when you actually start to see the title, it says natriuretic peptide B, NPPB, and its N-terminal equivalent. And I think the fact was that it's kind of unique in that if you look at actually the actual symbol or the gene is actually called natriuretic peptide B or NPPB. And so it actually, the proper name for this peptide is NPPB. And as always, as everything in life these days, if you do the gene etiology of this, you will see that there is actually some discussion on the utility of natriuretic peptides, and of course in patients with COVID-19. But I think part of the editorial was to focus on a little bit something new about natriuretic peptides, because as what was noted in the past is that we actually had some utility in regarding heart failure. But is that all that is known when we think about measuring natriuretic peptides? So in part, this rebranding of natriuretic peptides, I think, is really important. And the fact is that in previous time, it was really just for the diagnostic evaluation of acute heart failure, in which Dr. Lamb talked about and where guidelines have endorsed it and so forth. And in fact, vast majority of clinicians, if asked today what a cutoff would be used for natriuretic peptides, they would actually probably indicate the cutoffs that would be used to perhaps rule in or rule out acute heart failure. But again, that's just in the setting of congestion. But what we do know is that these peptides actually have some very powerful biological functions and so forth. And so, there is actually a major challenge when a biomarker's been actually perhaps painted or really focused on one application, to actually get individuals to actually be open-minded and look at the fact that there's actually different applications for natriuretic peptides. And perhaps this rebranding of the natriuretic peptides could be really just focusing on the biology, because these do have very potent biological functions, which were highlighted throughout the first few talks. And I think to kind of reiterate this point, one can look at another really good editorial in clinical chemistry by Dr. Mauro Bonica back in 2008. And the fact is that for major challenge for researchers and clinicians will be to demonstrate whether candidate novel biomarkers are useful for improving diagnosis and guiding clinical treatments. And I think is when we start to focus both on the biology of the natriuretic peptides and keeping that question in mind, we may actually see that there's different utilities that could be explored. So what is this new proposed universal definition of heart failure? So it was a consensus statement, and it was endorsed. It's a report by the Heart Failure Society of America, European Society of Cardiology, Japanese Heart Failure, and it was endorsed by several other groups regarding this consensus statement. So again, as Dr. Lamb has mentioned regarding the two more recent definitions by the ESC and the AHA, it has actually natriuretic peptides are at the forefront. So again, it all starts with the patient, symptoms or signs of heart failure caused by structural or functional cardiac abnormality, and it has to be supported by at least one of the following. And here we can see the level of importance of natriuretic peptides being at the forefront. Or secondly, if you do not have that, you can actually have some other objective imaging evidence of systemic or cardiogenic pulmonary or systemic congestion. And again, that places the emphasis of the natriuretic peptides at the forefront, similar to what we think of perhaps cardiac troponin with the diagnosis and the definition of myocardial infarction. So again, just to kind of highlight that the committee does a lot more than write perhaps recommendations. It actually provides important critiques of more up-to-date and recent guidelines. And so on your left is a special report that was published last year from the committee's thoughts on regarding the most recent ESC biomarker definitions and guidelines. So that's one report which should be available freely, and I would encourage interested individuals to read that. And then we actually just recently published our perspective on the universal definition of heart failure. And again, this was published in the Journal of Cardiac Failure. And just to kind of highlight the tables and the proposed cutoffs, and this has kind of been, this is a recurring theme regarding different guidelines and cutoffs, is that they actually start with two different groups. The ambulatory group, where we have these lower cutoffs of 35 for BNP and 125 for NT-pro. And obviously, for those who come to the hospital acutely, we have higher cutoffs of 100 for BNP and greater than 300. Note, What was actually not presented in this definition are the age stratified cutoffs, which we have seen from PRIDE and ICON Reloaded, that can aid in the specificity and the rule-in of patients with dyspnea who present to the ED. So next few slides, what's going to happen is we're going to actually talk about what some of the statements were in the universal definition and see how that kind of coincides and with some of our recommendations that we put forth on the analytical testing of the natriuretic peptides in 2019. So first off, the universal definition of heart failure states, in general, both BNP and NT-proBNP values track similarly and can either be used in patient care settings as long as their respective absolute values and cutoffs are not used interchangeably. And again, this has been highlighted by both Dr. Lana and Dr. Saenger. And I think it's important when we look at this is that we have to see that this statement still applies. The IFCC CCB does not believe that these assays should be interchanged. And just to reiterate, it should be like you should not alternate or perform concurrent BNP and NT-proBNP testing. We even go as far as to say that, you know, you probably want testing on the same instrument and don't mix it up, even if it's the same assay, but point of care versus, you know, core laboratory instrument. And the point is, the fact is that if people are looking at serial measurements, we want to try to avoid as much analytical noise in that system. And so the same laboratory test, the same laboratory NP test on the same, by the same manufacturer on the same instrumentation will mitigate analytical confusion. And this is important because we do this for other non-standardized assays that are used in monitoring treatment and follow-up in other conditions. And there's really, you know, the most common condition here that we do in a lot of the clinical chemistry labs is obviously serum tumor markers in patients with cancer in the monitoring aspect. And so here's an example of why we do not want to interchange or mix up BNP assays or NT-proBNP assays. So on the left-hand side, we see that here's just a simple method comparison between Beckman's BNP on your x-axis and Abbott's BNP on your y-axis. And you can see that there is definitely, you know, at lower concentrations, there seems to be a little bit better agreement. And as the assays, as the concentrations get up higher, there seems to be more divergence. And the fact is that perhaps, you know, one assay is reading perhaps 25% higher than the other. And so that's an interesting relationship that might state, well, you know, perhaps Abbott runs about 25% higher than Beckman. But that's not necessarily the case for individual patient samples. So you can see here, these patient samples, we see the opposite, that, you know, Beckman is running higher than Abbott. And in this particular case, at these elevated levels, Abbott's running significantly higher than Beckman. So simple relationship even between BNP assays, if you felt that the large method comparison was done and you felt comfortable onto that, they will still lead to differences and perhaps differences in interpretation of these discrepant values. So this applies to BNP, but it is also evident for NT-proBNP. So here's an example of Roche on the x-axis and a Siemens NT-proBNP on the y-axis. And again, at lower concentrations, perhaps below 300, we see very good agreement. And so the gray line is the line of unity where, you know, your y is equal to your x. And so you can see down here at this concentrations, at these lower concentrations, very good agreement. But as we start to get higher concentrations, perhaps with patients that, you know, have heart failure and being monitored for treatment, we start to see, again, there's a little bit of divergence between NT-proBNP assays where one assay is running higher than the other. And so perhaps you know, the overall, you know, regression analysis would only take, oh, perhaps it's only 10% higher for Siemens versus Roche. But again, the same caveat applies. That's the overall relationship. But for individual patient samples, we see that the difference can be more pronounced. And so to really prevent misclassifications while patients are on treatment and so forth, we really would endorse that the same assay performed on the same platform be used. And this should help to prevent some of this analytical noise, perhaps impacting or imparting different treatment due to patients on being followed with heart failure therapy. So again, this is nothing new because we've seen these types of relationship for tumor markers as well. So here's an example of PSA, probably one of the best harmonized serum tumor markers. And then here we see at different concentrations of PSA, we see one assay at a low concentration or at a mid concentration. We see it runs approximately 20% higher than the other assay. And so one could think, well, if I can establish this relationship, maybe 20%, I can use that to inform clinicians, just like BNPs, people monitor PSAs. But the relationship is not actually consistent, in that at even higher concentrations, perhaps, males with metastatic disease undergoing systematic treatment, we're seeing that the percent difference is even higher. So this is just to highlight the fact is that what we know about tumor markers, and that we do not want to, mix different assays together, or perhaps have patients monitored with assay A and then go to assay B and vice versa. We still want to maintain that type of approach, and we really think we should be using that same type of approach when we're thinking about natriuretic peptide testing for monitoring patients on therapy. So the universal heart failure, another statement that they mentioned, the fact is that they actually drew attention to the fact that the universal definition of MI, where elevations of circulating biomarkers troponin are both central to the clinical diagnosis and fundamental to the universal definition itself. So the group did recognize the importance of a biomarker being useful in regarding making the diagnosis, and they actually drew a lot of analogy to how high sensitivity cardiac troponin has really had a large impact regarding clinical management and care. And again, we as a committee, obviously agree that, and obviously cannot emphasize more strongly that we really need this close collaboration between the laboratory and clinical community in order to get a test to be appropriately used to make the best diagnosis and prognosis. And I think where we as a committee felt that perhaps the authors of the universal definition of heart failure could perhaps provide some a little bit more attention to is the fact is that some of the cutoffs that have been proposed, not only in the universal definition of heart failure, but in other definitions, are these lower medical decision cutoffs, this 35 for BNP and this 125. And again, as we start to probe lower and lower concentrations regarding clinical care and utility, we want to make sure that the laboratory and laboratory testing is able to meet the appropriate precision, accuracy at those low levels, such that patient care can be optimized. Again, the universal definition states that, there is obviously different diagnostic thresholds. They do mention the fact about, age can be used and so forth. But they said for common clinical purposes, simple thresholds can be established. And this is a point that was highlighted by Dr. Lamb. Yes, we can optimize by using age-specific rule-in cutoffs or perhaps higher cutoffs for ruling in for BNP, but perhaps just a simple threshold is useful just to get physicians used to adoption. And again, we as a committee felt that that is good in the fact that, that it is important to make messaging clear. But when we look at actually the manufacturers and the cutoffs that are used, what we see is this tremendous variation in cutoffs. And of the two cutoffs that have been proposed, specifically the 35 nanogram per liter cutoff for BNP, we didn't find any manufacturers that have a listed upper limit of normal or upper reference limit of 35. This was absent from all the package inserts. And in fact, only a few manufacturers did list the 125 cutoff for NT-proBNP. And when they did so, they really specified it for the most part for the younger population. So again, we think that these are important aspects that clinicians need in regarding for utilities and adoption of cutoffs, but we feel that it puts the laboratory a little bit at a disadvantage because there really isn't any sources to support some of these decision levels outside of the guidelines and recommendations themselves by the clinical societies. So again, here's a table that was published in our perspective that again is drawn from the tables that Dr. Saenger mentioned beforehand. And just for illustrative purposes, I listed one company that has BNP that's offered on different platforms, as well as an NT-proBNP assay, as well as a point-of-care assay. And what I just want to highlight the fact is that when we think of what the upper limit of normal is, and we see that the 35 has been proposed, we see nowhere as a 35, we see nowhere as a 35 being proposed for BNP on the two respective platforms. For NT-proBNP, we have the 125 that's actually stated, but only at younger than 75. And perhaps the closest, cutoff that's indicated here is, and again, this is obtained from the data sheet internally, is about a 50 nanogram per liter cutoff for BNP on the point of care device. And again, so none of these really do support the 35 or the 125 without any age specification. The second thing that's probably of note is that, as was mentioned earlier, and Dr. Saenger appropriately addresses quality control specifications. And here we can see that it's not a trivial matter. And the fact is that even at the upper limit of normal, some assays on different platforms achieve precision that may be less than ideal. So again, it is important for the laboratory to monitor their assays at the appropriate cutoffs, such that precise results can be maintained and be delivered to clinicians and patients. Again, 35 and 125, we also make a point to the fact is that, and was also highlighted earlier with the question and answer period, that there is no standardization or harmonization. And so that could be very problematic when we're thinking about using, just one cutoff is 35 and one cutoff is 125. And again, this is very similar to high sensitivity troponin, where there is no standardization or harmonization. But here, when we think about high sensitivity troponin, many have advocated that because we know there are differences, we should be using assay-specific cutoffs. And obviously for the detection of myocardial injury, there are definitely different assay-specific upper limits of normal 99th percentiles. So again, something that is perhaps something that needs a little bit further discussion when thinking about one cutoff for all different types of BNP and NT-proBNP assays. Finally, the universal definition does state that patient-level changes are needed to interpret it according to baseline levels. Natural peptides are higher during periods of decompensation compared to compensated periods, reflecting dynamic temporal changes. And here we do kind of agree with this, and we also highlight the fact that we do need a precision goal of 30%. Many of the trials are based on changes over time of 30% or lower, and these were derived for clinical trials looking at beneficial effects of different treatments as surrogate endpoints to see a 30% drop and so forth. And again, it's not even sometimes the 30% drop. Some trials have been actually designed to see a drop below a certain threshold. So for example, Dr. Lamb mentioned NT-proBNP, and some of the trials for NT-proBNP on patients on heart failure will now target concentrations below 1,000 nanograms per liter. So in summary, QC parameters have changed, tighter precision for natriuretic peptides. Of course, and as Dr. Saenger mentioned, we need less than 10%. And of course, with the newer definitions of heart failure, there's this interest in lower cutoffs, and that would be related to the 35 and 125 to rule out, as Dr. Lamb mentioned and discussed. There are differences in both natriuretic peptides and high sensitivity troponin assays. So this is very similar between both assays in that, differences will exist. And so you really need to know your assay, and you should be able to discuss and let clinicians know about that assay as well too. And finally, as a committee, we really acknowledge the efforts of the authors of the universal definition of heart failure for endorsing an objective biomarker of heart dysfunction, such as the natriuretic peptides. And with that, I thank you all for attending today's webinar. And if there's any questions, I'm happy to discuss.
Thank you, Dr. Kavsak, for your interesting talk that has raised several questions that I will rapidly to translate you because our time is finishing. One question, given that one of your slides referred or mentioned ProBNP and mid-regional ProANP, is will there ever be a role for measuring ProBNP?
So you're talking about the ANP and mid-regional ANP, ProANP?
No, yeah, but the question refers specifically to ProBNP, the precursor molecule.
Yeah, I mean, I think the part of the issue there is the fact is that an assay actually has to be widely available. So for ProBNP, there has been an assay that's been proposed, but it hasn't been widely studied and evaluated. And I think for any type of testing, and this even applies to some of the mid-regional ProANP, is that some of those assays haven't been widely tested, and in part haven't been tested in different populations. Dr. Lamb mentioned the importance of ICON Reloaded, which was a contemporary reassessment of NT-proBNP in a more contemporary heart failure population. And so I think this is just to say that when we're thinking about biomarkers and testing, we really need to have the evidence of the utility of that test before actually endorsing a test. And so, but it starts with a good test. So, we'll have to wait and see.
Yeah. Okay. And now to other specific and unspecific questions. The specific is do you expect to see new format assays with different epitope sites for NT-proBNP assays now the Roche assay is no longer under patent?
Yeah, I mean, I think this is what we discuss internally as a committee, and that's a very important point. In the past, where a lot of the NT-proBNP assays, the antibodies were licensed from Roche, and so an example I provided, the Siemens NT-Pro versus Roche NT-proBNP, that was compared to version 1 versus version 2, but they're both Roche assays, and so Roche antibodies, and so we still saw there that there's quite a difference, right? So measuring on the same platform. But I think that's an excellent point. And the fact is that when different companies start to develop NT-proBNP assays, we need to be certain that they're measuring similar analytes. And as we know, and which was discussed briefly, and the fact is that glycosylation on NT-proBNP can really impact on its levels. And so we know, which wasn't discussed, is that if you get rid of the sugars, I'll say that perhaps, what we see is that the NT-proBNP concentrations can go off the charts. So I think these are extremely important points that will require laboratorians and laboratory professionals to actually measure and address new assays when they come out, because I do agree with the person who posed the question that it's not going to be a simple thing to say, well, it's an NT-proBNP assay, I can use the same cutoffs. You really want to start to assess it if it is similar to other assays, for sure.
Okay. So in the same line of your answer, there is a very general question saying, in your opinion, what would be a perfect BNP or NT-proBNP assay analytically that the clinicians need?
Well, boy, wow. If I had that, I wouldn't be sitting here, would I?
Wow. $10 for the answer. 100.
Yeah. Sorry, I have to talk to my patent attorney for that. You know what? I think the fact of the matter is that I think if we can start to probe more of the biology, and I think if we can understand if there's a possibility we can pick up the different isoforms and what they actually do. I know, there really isn't any utility to measure both NT-pro and BNP, and though people are looking at ratios and so forth, but I am thinking that there may be more ways that we can actually probe the biology. And I think what Dr. Januzzi's in his editorial was kind of, provoking in the fact and encouraging is that we should be thinking about these things, these NT-proBNP, the NPs, a little bit differently. And I think if we start to obtain different assays that could actually probe some of that biology, perhaps a little bit better. And in fact, and this is where perhaps ANP and the mid-regional pro-ANP, they seem to be differentially affected with the ARNIs, and the fact is that they seem to be perhaps a primary target. So maybe that would be a really good biomarker. So I do think that there's more that we can do when we start to assess the biology. And so an assay that can do that, I think, is an assay that will be worth, supporting, measuring, and exploring for sure.
Yeah, given that the organization has given us 5 extra minutes, let me ask you, do you believe that the answer for this question should be the assays that can measure the 132 BNP sequence and the 176 NT-proBNP sequence be the solution, or at least the proposed reference methods?
Yeah, so the only problem is that in biology, that's not the only form of the BNP, and so we really have to figure out what is the form that's no longer functioning, which will no longer bind the NPR receptors. I think that's important, and so there definitely has been a lot of work looking at the different degradations of the BNP, and I think I think that's important. The other aspect is that it's not so. What's another way to say this? Even if it was the fact is that, say we made, I don't know, like a perfect thing to say, it has to be 132, but we know that BNP will start to be degraded by different proteases, possibly nephrolized in a weak source as well, but that'll be degraded. But some companies will have epitopes and have antibodies selected different regions of the quote unquote BNP. So you will expect to see differences in concentrations depending on where those epitopes lie. So they could still say, I can measure the full BNP 132, but when patients are on different types of drugs, or perhaps are experiencing different types of events or what have you, or in vivo processing of the BNP, they may not yield the same results. So it's a little bit more complex than just saying, 132. And the fact of the matter is, and then with the glycosylation that occurs, that's a whole nother matter regarding NT-pro and pro-BNP as well, regarding processing and cleavages and so forth.
Okay, thanks for the answer. So given that we are just arriving to the end of our time, I would like to thank all people that is on the other side of the screen that has attended this webinar. Thank you for attending us, and hope that it has been useful for your clinical and laboratory practice. But I also would like to thank the speakers, Dr. Saenger, Professor Lam, and Dr. Kavsak for their interesting presentation, but also to acknowledge to Dr. Hamilton and Mrs. Esmeralda Esquerra that were in the backstage coordinating all the good functioning of the seminar. Thank you very much for your nice job. And obviously, we should acknowledge to IFCC for having the initiative to maintain this kind of seminar, webinars, and learning activities. But before closing the session, let me say some take-home messages. There is a number of unanswered questions, but all them will be replied by email to those who pose them. The certificate of participation will be provided at the end of the activity after answering 3 easy questions. So once you have answered the questions, click in Show My Scores at the end of the page, and you will get the certificate. The video, the content, will be on demand and will be available on short, and you will be informed by email. But in addition to these and others webinars, the ICC is pleased to announce that is making different courses available to the participants. The courses are based on the concept of adaptive learning that is closest to the personalized education and are designed to help the takers of the course to assess the knowledge, to maintain and gain competence in the areas of research, of work they have. Among these resources, you will find the link to a website that houses around 100 courses covering different topics in laboratory medicine. The registration is free. It takes more than 30 seconds, but to access the courses, you need to be registered. So you are encouraged to take advantage of this opportunity. And obviously, there will be soon other free ICC webinars. They will be announced by the usual ICC communication channels, email, website, and the ICC social media. And for finishing, thank you again to all you. Goodbye and peace to the world.